Dear colleagues, I'd like to share with you my experience of treating IVM and the ways to include symbolization radicality. First question, typically, is which IVM should be treated? Obviously, the absolute indications is IVM ruptured. We need to treat IVM without rupture. It is still debatable. In 2014, Penumbra study launched these processes, and right now there are 722 publications on this issue, mostly criticizing the approach. We have analyzed, when we've got a series of IVM, we operated them without ruptures, and when we analyze them by breaking down into two groups, ruptured and unruptured, what we found, if we treat unruptured malformations, then the rate of bleedings is higher. At the same time, we all know IVM rupture predictors. They've been published pretty long time ago. The most important of those predictors are aneurysm afferent, arteries, intracranial aneurysm, and venous varicosis. Also, intravenous fistulas are important because it's a high flow malformations. Venous stenosis are also important. They can cause ruptures, and angiogenesis. When we analyzed predictors in IVM embolizations, we saw that in ruptured IVM without predictors, the level of hemorrhagias is much lower. In IVM that were unruptured, but with predictors, the level of complications is comparable with ruptured IVM. It leads us to the conclusion that surgeries of IVM, even non-ruptured, are necessary if there are predictors for rupture. So if we'll see aneurysm, venous varicosis, aneurysm on afferents and intranodal, such malformations would be better to operate, even if it would be possible to achieve total embolia, but the dangerous parts of malformation should be worked on. As for unruptured IVM with epi syndromes, good efficacy of embolization was achieved, even if it was only partial, not total embolization. The decreased flow of IVM was achieved, and many patients showed signs of improvements, like the severity of events was decreased by 34%, total absence of events 59%, and no positive developments, only 7%. Sergei Yakovlev, when he was operated, I read his protocols. It was about a quarter of a century ago, and looks like fistulas were closed because several balloons were installed in IVMs, and all those years the patients had no events. So this is another indication to IVM treatment. Which methods can increase IVM embolization radicality? First, a new embolizer, FIL, gives us good results. It's slightly different from Onyx. It is also dissolvable, but the polymer is different. Different concentrations should be used of both Onyx and FIL. Those two methods can be combined in one catheter. It is the FIL-Onyx technique, and it also improves radicality. Corking also gives us good results for creating a cork in the afferent. It enables us more aggressive embolization of IVM and increased radicality. Two-catheter technique, when we had embolizators from two catheters, changed the hemodynamics in IVM. and a more total embolization is possible if the transarterial embolizations are capabilities are exhausted, or there is no such a possibility due to small afferents or afferents are such that embolization is impossible, then transvenal embolization is an option. And the kissing technique, when simultaneously the embolizer is introduced through an artery and the vein. Regarding embolizers, onyx and fill, DMCO soluble. The difference is that polymers are different. The second major difference is that fill has colored costrate and onyx is colored with tantal. Since fill has a contrast, if we introduce onyx, we see practically nothing through it. When we use fill, we see the vessels and they remain part of IVM. So a tactics even can be that at first stage we use fill and at a later stage we use onyx. It is possible because onyx can be seen through the fills. This is how we can compare the work of those onyx. The precipitation is different. Dissemination through vessels is also different for those two agents. Look, here you will see how it is spread out like lava in one layer. Here we can see onyx, and we'll see what is the result. Now look at fill and how it works. It goes in fragments, like in grains, and sometimes in embolizing this not be that good, because when it gets in a vein there can be an impression that it goes through a different part of malformation simply because precipitation is through such fragments. So you see that we get pretty different clots even in water. Regarding physical properties, they are also different. Fill is more dense. Look how it behaves under pressure. Onyx is softer, so in open surgery, the behavior also will be different. This is how they are distributed through vessels. For example, in arteries, many embolized with onyx, so it goes through an artery without full closure of a lumen, gradually filling in an artery, and then a reflux is developed, and it should be formed. I can see it on the screen with the pointer. Now you can see that it should be developed gradually because it doesn't cover the entire lumen instantaneously. With fill, the process is faster. This is how it goes through an artery, then reflux is developed, and you can do it with practically the first attempt. It's pretty firmly fills in the afferent, so very often we'll see such rolls around an afferent, and we should be very careful with it, because if it continues developing, the result can be bleeding. This is how onyx works in a vein. When it gets inside, it creates such a stripe which closes the venal lumen, and then from different part of IVM IVM, it gets to a vein, gradually filling it in. So as soon as it fills in, multiple introduction is necessary to a vein through the IVM body. With fill, the situation is slightly different, so it's a faster technique. It straight away gets to the venal lumen. It can be filled in pretty firmly, and this part of the IVM node is filled in with an embolizing agent. The methods for simultaneous application of fill in onyx. How does it work? First, we introduce fill, and we can close the IVM totally or subtotally if it's not that big. In open surgery, we often see that small fragments of IVM, even if an embolizing agent is around, they may not be cloned. It can be a source of hemorrhaging. So this technique can be added with onyx. Onyx is put in the same microcatheter, and then it fills in gradually the IVM through fill. We can see the previous embolizing agents, how it goes through the vein, and then the IVM body can be closed in a more firm method. This is an example of using fill in IVM. A microcatheter is introduced, then fill is put in, and the IVM is pretty quickly closed totally and excluded from the blood flow. That's a bigger IVM embolized using fill. We saw partial filling of the IVM artery, and we started putting in onyx in the same microcatheter, fully filled in the IVM body. Here the picture looks similar to a pre-operational angiogram, and we can see the total occlusion of an IVM. Here how it looks like in open surgery. White is fill, black is onyx. Both embolizing agents are pretty easy, convenient to use for removing IVM. You can see that it's totally bloodless procedure for removing IVM. Here you can see how onyx was put in directly through fill. In microscopy, what's interesting, fill precipitate quicker than onyx. However, when we study how they disseminate through vessels, you can see that fill goes to smaller vessels. So it seems that it's more dense embolizer, but it can penetrate small vessels pretty nicely. One of the methods enabling to considerably increase radicality is transvenal embolizations. It's not possible in all types of IVM. When we started working on IVMs, initially we thought it's very dangerous, but it's transvenal embolization is performed by an experienced surgeon, and if there are indications, then we even now do it stage by stage, not fully removing IVM and operating through veins. If everything is done correctly, then the risks of both TVE and TAE are comparable. This is our pilot study. We compared the risk of TVE and TAE in various groups, and in both groups we saw radicality much higher. Of course, when we go to TVE, then of course IVM should be totally occluded. Here, we also do not see any difference in invalidization and mortality in subcortical. We also don't see any difference. Diencephal malformations, we also do not observe any difference in radicality, in invalidization and mortality. Radicality is much better. What are the TVA advantages? Transvenal embolization, higher radicality, possibility to embolize in the absence of accessible afferents, low risk of ischemic complications because there is a lower chances that the embolizing agents would reach the healthy vessels, and also low recanalization level, because if you remain vein functioning, even if you don't see it on angiograms, there is a risk of recanalization. So the vein should be closed, whether it's transarterial or transvenal. And of course, the occlusion is necessary at the final stage of embolization. So what are the risks of TVE? Of course, the indications are limited. Not all IVMs can fall under this. It is not recommended to use it broadly. Only experienced surgeons should perform it. There is a risk of hemorrhagia if some mistakes are possible or malformations is not totally occluded, and there are limited possibilities to correct the intraoperational complications. For example, if the only vein is ruptured, there can be catastrophe. Here is an example which I show pretty often. This is one of our first transvenal embolizations. Here there are clear indications to transvenal embolizations. This is the only vein, the only one for 2 nodes, and initially the anatomic node is closed transarterially because there was a good transafferent, and the other hypothalamic was closed transvenally. The indications was the only draining vein, unaccessible afferent, a smaller catheter diameter, and a smaller node. Here we used balloon protection of cranial artery. The microcatheter was, the guide catheter was put directly to the direct sinus. Microcatheter directly, transvenally reached the IVM body, and we saw a total occlusion. Side ventricular IVM, you know that the rupture risk is very high due to location in this ventricular, and operating such IVM, ventricular bleeding, is a pretty frequent complication. Here we catheterize the vein, total occlusion of malformation in the lateral ventricular without any complication. IVM of a brain pentacle, functionally highly significant element. There was no transvenal access, but if you operate in stem elements, transvenal approach is preferable because there is no reflux, and the probability of close perforating agents are much low. Of course, you can do it through a malformation node, but you should work very carefully trying to fill in only the malformation body. Kissing. What is about this technique? With such malformation, when there are both good afferents and the only draining vein, small IVM, you can see that vein as stenosis. And typically such vein with stenosis means a huge risk of IVM rupture in postoperative period also. But it is good for transvenal embolizations because venal reflux is easier to develop. So here we use 2 catheters, one venous catheter, one in artery. Total occlusion of IVM in 1 stage. Corking has been described quite a while ago. A microcatheter is introduced, and one is detachable, the other is non-detachable. Coil, I introduce small amount of embolizing agent, onyx, fill, glue, whatever is preferable for a particular surgeon. And in some cases, glue works best. Now, perhaps fill would be an option, but you will not be able to see it perfectly through coils, so the IVM is filled in with the embolizing agents. But what is the risk here? If you're too aggressive with filling it in, you can reach rupture of vessels. So you should be very kind of careful in terms of dosage. This is an example of corking microcatheter with detachable distal part. Coil, you can see that the cork is developed in angiography. You can not see that the vessel is filled in. And then further on, IVM is in total occlusion. What's the best to increase radicality? Of course, it's a multimodal approach. Of course, there are good possibilities for embolizations. In our series, we achieved around 70% endovascular radicality. Still, 30% of malformations should be treated further, and if it's possible to remove them, we remove them. If we did subtotal embolization of an IVM, and if we see that the remaining part is kind of dangerous, if it's subtotal embolization with a huge risk of rupture, so we straight away go for microsurgery. We do not wake up patients and do not see whether he'll what's going to happen with him. We straight away remove it. And the IVM in the posterior cranial fossa, we had a number of cases with when a patient woke up and then in 12 to 18 hours, bleeding developed after surgery, and bleeding in the posterior cranial fossa typically is a catastrophe, and we lost several patients. So in this case, we have a more aggressive multimodal approach. Even if we embolized an IBM, it is possible to remove such malformation, and we go for it. When we began to use a more aggressive multimodal tactics, you can think that it brings more complications simply because open surgery is used more actively. But we think that it enables us to increase radicality without sacrificing functional result. That was a prospective cohort study. The inclusion criteria were quite standard: age under 75, technical possibility to use endovascular treatment, signed informed consent, non-inclusion criteria, recent IBM rupture in the past 30 days, comorbidities, and so on. The series was 537 patients, of who 75 were with multimodal techniques. The control group, 236 patients, and some of the patients were taken for additional groups. I'll explain later. Pseudo-randomizations was performed with PCM, and two totally comparable groups were shaped for making the study randomized. So we compared those two groups, which match in terms of the main science, and we compared the study in the treatment outcome. Additional groups. Straight away, we achieved 100% radicality because multimodal techniques is not necessary. There was a group of palliative treatment with patients with heavy malformation, where we closed only the radical parts. So it's not a separate group. We take the patients with the epileptic treatment. We take them from both groups. And the good results were achieved in terms of epilepsy treatment. The primary endpoint was 100% radicality. The second endpoint, subtotal occlusions of malformation. Regarding the primary endpoint, of course, when we applied microsurgery, the radicality was much higher in a multimodal group. Subtotal occlusion, the rate also was higher in the multimodal group. At the same time, the recanalization frequency was comparable. We expected to get roughly the same level of complications by groups, but it happened that in the multimodal groups, the level of bleedings was much lower. The level of invalidization also was much lower in the multimodal group, and in this series, we didn't observe morbidity. Perhaps the group was small, so this is not statistically significant difference. Thank you for your attention.